So thank you to Asham. And I'll just acknowledge I've modified a presentation that was given to me, so I'll just acknowledge the original writers. I might just actually start off by asking everybody to introduce themselves, because Sabdi's here from Asham, and he might might want to introduce themselves. So if you could just briefly introduce yourselves, what's your role and where you're joining us from?
Hi Claire, hi everyone, my name is Sabdi. I'm a project officer from Ashams. I'm joining from Sydney.
Oh, you're in Sydney, thank you Sabdi. So Aaron?
Sorry, I hope that's coming through. I was having trouble setting up my sound. Is that coming through okay?
Yes, yeah.
Yes, I'm Aaron Kennedy. I'm coming from home at Gargett in Pioneer Valley, just outside Mackay. My role is the clinical editor for Health Pathways. So my sort of ulterior motive tonight is just to pick up any clues of things that might need to be updated in the pathways, so that that's available for everybody else in the community. We had the privilege of doing all our initial pathways with Donna and Claire way back when we started Health Pathways.
Great, thank you, Aaron. Rosie?
She doesn't seem to be there, so I'll say that I'm Donna, the nurse practitioner, and I'm very happy to be here tonight, and I work in the Mackay Sexual Health Clinic.
Tony?
Yep, Tony Simmons. I'm the General Practice Liaison Officer and Integrated Health Manager, and same as Aaron, coming in from Mackay, and also an interest from a Health Pathways perspective.
Great, thank you. And I'll just see if Rosie can hear us again. Sue, we just introduced. Do you want to just introduce yourself briefly? Sorry to.
Sorry, it's taken me this long, 15 minutes to get on. So
Okay, so Sue is.
I'm the nurse practitioner midwife at the Mackay Base Hospital.
Great, thank you. And Rosie? Rosie, you could put in into the chat box if your sound isn't working, if that works. All right, okay, well, I might press on. Can I just check everybody can see the PowerPoint? That's okay. I'm just going to start off by talking about just acknowledging the Mackay Sexual Health Service. So Mackay Sexual Health, I've worked at for 20 years now, which is a bit embarrassing. So the core business is screening, testing and treatment for sexually transmitted infections. The service also does HIV rapid testing, which produces HIV results in 20 minutes. We do HIV pre-exposure prophylaxis, management of bloodborne viruses, transgender care, sexual dysfunction, and termination of pregnancy information. So I'll just acknowledge the service, and also want to acknowledge Donna Piney, who's our wonderful nurse practitioner at the service. And those of you who've met Donna will just know that her knowledge is very, very broad, and she's just fabulous. So and she knows way more than me, so I may defer to her. And Donna, please don't hesitate to interrupt me if I say something that's incorrect. Okay, Donna, can I just check you can hear me?
You're just on mute, Donna. We can't see the presentation either, Claire.
You can't. Okay, that's yeah. You could see it before though, couldn't you?
Yeah. Yep.
Okay. So you can't see anything. And what can you see?
Just everybody's video.
Okay. Can you see it now?
Not yet. No.
Can you see it now?
No.
Maybe stop sharing and then reshare it again. I think that's happened sometime.
So no good still. Okay, show hide participant, show conversation, share content. Share content. Yeah.
Yep, we can see it now.
Okay. Is that a full screen now?
Yeah.
You can see? Okay. All right. Thank you. I don't know what happened then. I'm very good at Zoom, but a bit scared of Microsoft Teams. So I don't think I'm going to change the screen now for fear of losing it. So everyone can see the screen and everyone can hear me. Yeah.
Yeah.
Okay. Thank you. Learning outcomes today is to demonstrate confidence in discussing sexual health, explain the importance of screening and testing for STI, talk about contact tracing and its role in managing STIs. I'm also going to talk about gonorrhea and syphilis. I've sort of slightly modified the slides so it's particularly suited to Mackay and the situation in Mackay at the moment. And if I've got time, I was going to talk about a few topical GP sexual health issues, so PrEP, MTOP and mycoplasma. Okay, so just epidemiology. So chlamydia, this is chlamydia notifications in Queensland. Basically, for the first 3 quarters of 2020 and then annually prior to that. So chlamydia levels are sort of slightly increasing. They're teeter around 500 per 100,000 per year. The prevalence of chlamydia we know in young people is about 5%, and the notification rates sort of reflect that. But gonorrhea is a little bit different. So gonorrhea is less prevalent than chlamydia, so there's lower notifications. But the notification rates are actually increasing. So in 2015, there were 60 per 100,000, and it actually doubled by 2019. Now, this is the local situation in Mackay. So like for years, we've had sort of about 5 gonorrhea notifications a month. And then July 2019, we suddenly had 31 notifications of gonorrhea, and things have continued to sort of chug away since, except in April, which I'm at, was sort of COVID month, I suppose. So everybody must have stayed at home in April, but we have got a large increase in gonorrhea notifications, and it's not really the when we've looked at the stats and the index cases, it's not really the classical people who get gonorrhea. So some of them are men who have sex with men and injecting drug users, but not all of them. A lot of them have been heterosexual as well. So one of the take-home messages today really was to increase gonorrhea testing in Mackay. Now, the other issue that we have here at the moment in Mackay is an increase in infectious syphilis notifications. So that statewide, there's been a rapid increase of infections from 2015 to 2017. But in Mackay, Donna actually just sent me the the Mackay infectious syphilis notifications today, and our notifications we're up to nearly 20. We're up to 19 the year to date. So it's actually basically doubled from 2018 and 2019 to 2020. Now, 5 of the health districts in Queensland have been declared areas of syphilis outbreak. Mackay hasn't as yet, but I was just looking at the colours today after Donna sent this to me, and we're sort of approaching 20 per 100,000 notifications this year. I think we'll only need a couple more to get there. So I think our colour's about to change. And it may be that Mackay Mackay Health Service will still soon be announced as an area of syphilis outbreak. So that's just a really concerning thing as well, just at the moment. And I'm going to talk about syphilis and the management soon, but really syphilis is a drama. It's really, we're still getting congenital syphilis notifications in Queensland, and every case, we sort of have this thing that every case of congenital syphilis could be prevented. So congenital syphilis really is a drama. Okay, so any questions about the epidemiology at all? And as there's only a few of us, I suggest speaking rather than typing into the chat box. Okay, no worries. Well, I'll keep going then. So just broaching the subject. When would you start a conversation about sexual health testing was the question I wanted to pose to people. So did anybody I mean, myself, if I'm working in general practice rather than in sexual health, I mean, a time when I start conversations about sexual health testing is if I'm doing a pap smear, though we're not allowed to call them pap smears anymore, but if we're doing cervical screening, it's a time when I tend to talk about sexual health testing with people. Does anyone else have a particular time in GP when they talk about sexual health testing? Okay, no, that's fine. It's probably, yeah, I know that we don't have many GPs here. So so you can bring up the subject opportunistically. You can use a hook. It can be part of a reproductive health consultation, or it can be because the patient themselves requests a checkup for STIs. So just basics of sexual history taking. I mean, one thing about taking a sexual history is there is a lot of evidence that people are notoriously dishonest about their sexual history. If people are quite guarded and don't disclose an awful lot of information, that's sort of pretty common. But if somebody wants a full sexual health screen, then generally if someone requests something, we tend to do it. But just some basic questions is, when did you last have sex, or when did you most recently have sex? Was it with a male or a female partner? And don't forget that it can be both genders as well. And then what types of sex are you having, which is just important if you need to do swabs from different areas. Okay, so any questions so far about anything? I'm a little bit paranoid that people can't hear me. Donna, did you want to add anything at this point?
No, thank you, Claire. No,
okay.
Your voice is clear. Thank you very much.
Yeah, I'm just a bit scared to open the chat box in case I lose the main screen again. So
I can keep an eye on it as well, Claire.
Oh, thank you. That'd be great, Kayla. So if there's something in the chat box, if you can just ask me, that would be brilliant. Thank you. So screening and testing. So the difference between screening and testing: screening is testing in a high-risk population, in an asymptomatic high-risk population, or an asymptomatic population who fulfills screening criteria, like young people for chlamydia in the GP Red Book. We're basically asked to screen for chlamydia in 15 to 29-year-olds annually. So that's, it's sort of an age-based screening, I suppose, but not necessarily a high-risk group. And testing is testing in people who are symptomatic, basically. So who do we screen for STIs? So the first thing I was going to ask is, who are the high risk groups for STI screening? So do people want to just write in the chat box any high risk groups for STI screening?
So we've got from Rosie, MSM, Indigenous.
Excellent, thank you. So yes, so the really high risk group are Aboriginal and Torres Strait Islander peoples and men who have sex with men. There's other groups that may be high risk. So we talked about young people 15 to 29. often fulfilling the criteria for chlamydia screening. And sex industry workers can be at high risk, although a lot of sex industry workers are very good sort of business people who take great care of their sexual health as well. But they are sort of considered an at-risk group. And there are other, who else should we test? Well, if the patient requests a test, often that's a little bit of a trigger to test for everything. Obviously, you can explore concerns, but people aren't necessarily honest about their sexual history. So if their sexual history indicates the need for testing, even though they're not in one of those high-risk groups, if they have symptoms and signs of infection or immunosuppression, if you need to exclude co-infection in patients with hepatitis B or C or TB, and if people are diagnosed with another STI, it's best to test for everything else. So particularly with gonorrhea diagnoses, it's really important to test for syphilis and HIV as well. Because the risks for gonorrhea do go hand in hand with risks for HIV and syphilis. Okay, now Ascham has a fantastic guideline on management, testing and management of sexually transmitted infections, which I fully recommend. And they have a testing tool for asymptomatic people, which has different steps. So the first step we've already talked about, which is sexual history taking. The second step is basically deciding who to test and how often the test should be done. So there's a very informative sort of spreadsheet. I think we've got a laminated copy of this at Sexual Health. Basically, if you look at your risk group, so for instance, young people 15 to 29 should have chlamydia annually, which we've already talked about. They should have hepatitis B once to confirm their immune status. But syphilis and HIV, you certainly should consider screening, but it may depend on their sexual history and their local STI and HIV prevalence. And I'll talk about that in a second, because just at the moment, we should be considering gonorrhea testing in everybody that's having chlamydia testing, just with the situation at the moment with gonorrhea. And then if you look at higher risk groups, so for instance, men who have sex with men, chlamydia, gonorrhea, syphilis and HIV should all be at least annually and up to 4 times a year. And then there's also guidelines for hepatitis A, B and C. So this is a really good guideline for just clearing up who needs what tests when. The next question is how to do the test. So where the specimen site should be taken from and the test type. So for instance, for chlamydia in females. So when I'm working in GP, I often do a first class catch urine for chlamydia. But in actual fact, the self-applied high vaginal swabs are a little bit more, moderately more sensitive than first catch urine. So ideally, either an endocervical swab for chlamydia if you're doing cervical screening at the same time, or a self-applied high vaginal swab are the best ways to test for chlamydia. First catch urine is sort of, well, it's probably my lazy way of doing it in general practice. And all of those tests are sent off for PCR tests. Gonorrhea is pretty similar. Except that we do like to have a culture as well for sensitivity testing if a discharge is present. For trichomonas, we actually do have a PCR test as well now, and that's replaced the previous sort of swabs and slides that we used to do that were quite insensitive. For males, basically first catch urine is best for chlamydia, and throat swab and rectal swabs can go off for PCR as well. And I'll just talk in a second about self-applied swabs. For gonorrhea, it's pretty much the same, except that we do like to have a normal culture swab if any discharge is present. And trichomonas, again, a first class catch urine. Syphilis, HIV and hepatitis are all blood tests. So there's other tools. Ascham do have some guidelines on self-applied swabs. So we do a lot of these self-applied vaginal swabs in sexual health clinics. So we use the chlamydia and gonorrhea PCR kit, but we actually give the patient instructions. We usually get them to pop into the bathroom or the treatment room and take their own self-applied vaginal swab. And mostly we actually ask people to do their own anal swabs as well. And again, this guideline has instructions for a patient to do their own self-applied anal swab, which is really useful. Donna, did you want to talk about testing at all? Because you do way more of this than I do, particularly in high-risk people.
Not at this stage, thank you, Claire. It's all
Okay.
good.
All right.
It's all good.
Thank you. So yeah, so often what I say to people in GP land, not so much in sexual health, because really by walking into a sexual health clinic, people have announced themselves as being high risk, which sounds terrible, but we do see a high risk group. In general practice, what I tend to say is these are the tests that we can offer you, and this is the sort of risk category that you're in. So this is what I suggest you have tested. And at the moment, in low risk people, it used to just be very low risk people. It used to just be chlamydia, but now it's chlamydia and gonorrhea. So by low risk, I'm sort of talking about school kids, 15, 16-year-olds really are, if their partner is another 16-year-old, they really are very low risk of STIs. So that particular group, chlamydia is really the only thing that you need to think about screening for. But as I say, we're just adding on a gonorrhea test. If there's any other risk factor at all, then we do tend to test for everything. Okay, and so that's just, the pharyngeal swab we take in the clinic room, but we tend to get people to do their own vaginal and anal swabs, which are self-collected in the bathroom. Oh, seem to have repeated that. Okay, so any questions about STI testing or any? I'm happy to take any corrections as well.
There's nothing in the chat box, Claire.
Okay, no worries. Thank you. All right, so we're going to go on to talk about clinical presentations, which is a bit gets to the exciting part. So this is a leading question, but if a person has an STI, are they likely to have symptoms? Are they most likely to have symptoms? Yes or no? So do you mind typing that into the chat box?
So we've got no, not always.
Okay, excellent. So yeah, everybody, I thought everyone was. So no, I mean, usually people with STIs are asymptomatic, particularly with chlamydia infection, where 90% of infections are asymptomatic. So just a quick gonorrhea quiz. So gonorrhea in women is commonly asymptomatic. So true or false, if you could type that into the chat box. Originally, Sabdi gave me this presentation in Zoom, and Zoom does polling, but unfortunately I don't know how to poll in Microsoft Teams. So is it mainly true or false?
So we've got everyone saying true.
Yeah, true. So so gonorrhea in women, it's not quite as commonly asymptomatic as chlamydia. So chlamydia is 90% asymptomatic in women, but gonorrhea is more like 80% asymptomatic in women. Okay, how about urethral gonorrhea in men?
So we've got true. True.
Yeah, so thank you for that. Actually, this is true, and I was a bit surprised when I saw the answer to this, because I actually had a bit of a misconception that urethral gonorrhea in men was more commonly asymptomatic than symptomatic, but actually only 10 to 15% of men have no genital symptoms. It's different at other sites, so if the gonorrhea infection is the pharynx or the rectum or the endocervix, it's more likely to be asymptomatic, but actually urethral gonorrhea is more likely to be symptomatic. Okay, so the best way to test for genital gonorrhea in general practice is which of these? So if you could just type the letter into the chat box.
So we've got Rosie saying D. D. D.
Excellent. So, so the audience gets 100%. So yes, so in men, a urine test is fine, and a first pass. What you want is actually a dirty urine specimen with lots of urethral secretions. So it's a first pass urine. So the first little bit that comes out, but it doesn't have to be an early morning urine anymore. But in women, a cervical or a vaginal swab for PCR is more likely to show, is more sensitive, basically. Okay, so gonorrhea clinical presentation in women. They can present with cervicitis or vaginal discharge or pelvic pain and abnormal bleeding if they've got pelvic inflammatory disease, but most commonly they're asymptomatic. Men, they can get urethral discharge or irritation or pain when they pass urine. Some can be asymptomatic, and men can also get untreated infection can lead to epididymitis and chronic pain. And throat infections are often asymptomatic. Rectal infections may be asymptomatic or present with discomfort and discharge. Okay, so this is just so classically gonorrhea produces a more purulent and more profuse discharge than chlamydia. Having said that, you always get ones that are different. You get lots of gonorrheas that don't have a great deal of discharge and lots of chlamydias that have purulent discharge. But this is sort of the classic gonorrhea presentation with the sort of more profuse, sort of cloudy discharge. So testing we sort of already touched on. So we like to do a PCR swab from the sites that are needed as per the sexual history. But it is good, particularly if someone has a discharge or if they come back with a positive test, to get a culture sample because of rising rates of resistance to both penicillin and ceftriaxone. These are the treatment guidelines. I'm just going to try and get the light on in this room by standing up. Sorry. There we go. I've got a movement light in my office. So uncomplicated infections, basically we give ceftriaxone. The dose is increased to 500 milligrams and it may be increasing to a gram, but I'm going to ask Donna about that because I half remember a conversation about this. And we also give a gram of azithromycin for gonorrhea infections as well now. So it's both ceftriaxone and azithromycin, and basically the same treatment for pharyngeal infection. Yeah. Donna, who's the group that now get a gram of ceftriaxone, or was that a dream?
Not in the UK, not in Australia yet.
Right, yeah.
In the UK.
Okay. Was that just people with pelvic inflammatory disease, or was it all gonorrhea?
No, in the UK, they've had to increase up to a gram for all of their mainstream gonorrhea patients.
Right, thank you. I know we'd talked about it, but I couldn't remember the details. Okay, that's good. So follow-up of gonorrhea, no sex for 7 days, look, we don't have so much drug resistance in Australia. The proof of cure we do at 2 to 4 weeks, and then we actually retest at 3 months. Partner notification, we go back 2 months for gonorrhea. And big take-home message is full STI screening for including HIV and syphilis anyone that comes back positive for gonorrhea. And I can see Donna smiling and nodding because she reminded me to try and get that message across. Okay, so there we go. So any questions about gonorrhea at all, or did anybody want to add any comments?
There's nothing in the chat box.
May I just add that there have been, Sue will know that there have been a few gonorrhea diagnoses in pregnancy and late pregnancy. So in a hospital setting, it's very important, perhaps GPs are not aware that in late pregnancy, then babies need to have eye swabs done when they are born for PCR swabs when they're born.
Thank you, Don. I remember that from way back when I was doing when I worked at the base hospital as a PHO, swabbing the baby's eyes and always sending them off for chlamydia and gonorrhea. So yeah.
Well, in our mainstream clinic, I will have men in their 20s who will say, I've got a discharge from the eye. It must be, it's that goddamn swimming pool that I was in 2 weeks ago. And it's got nothing to do with the swimming pool. It's to do with the fact that it's a disseminated gonorrheal infection that probably has started and will come up on a positive urethral swab. Yep.
Great, thank you, Donna. Any other questions or comments at all? Okay, if not, I'll move on to syphilis. So I'm going to get Sue on red alert for syphilis. Yeah, and I talked before about really we are on alert for syphilis at the moment, and it could be that soon will be an area of syphilis outbreak. So syphilis, it can be confusing and complicated, but it also it can be simplified for GPs as well. As a clinical presentation, it can imitate lots of other conditions, and we've had such interesting clinical presentation of syphilis and sexual health over the years. It's categorized into stages, and the stage of syphilis dictates what treatment the patient needs. So syphilis quiz. So syphilis symptoms includes, if you could just put the letter into the chat box, that would be great.
We've got A, D, D,
yeah, so it is all of the above, and yeah, syphilis, I think it used to be the TB that was the great mimicker, but I think syphilis is really the great mimicker of other conditions, and yeah, the rash that you get with syphilis can be really confusing. And one of the things we've actually seen fairly regularly is primary and secondary syphilis presenting at the same time. So people who've got a sore or a painless ulcer or a chancre actually having a rash on their hands and soles of their hands and the palms of their hands and their soles of their feet at the same time. So how is syphilis transmitted? If you don't mind typing that one in. So is that mainly D as well, Kayla? Yeah. Okay, so it's another all of the above. We don't have all of the above multiple choices in our exams at JCU because all of the above is always more likely to be the correct answer. But lots of different methods of syphilis transmission, and you can sort of auto-inoculate. So regularly you'll see chancres in the vaginal area where you've got more than one lesion because one lesion is sort of auto-inoculated and caused another lesion. Okay, and the screening test, which is the correct screening test for syphilis?
So we've got B.
Yeah. Yes, so B is the correct answer. The screening test is actually a blood test. We do now have a PCR swab for syphilis, but obviously that's symptomatic testing rather than a screening. But it is great that you can now actually send a PCR swab of the lesion for syphilis testing. Okay, this is just a case of someone I saw not that long ago. So a 17-year-old Australian Aboriginal young man who came to clinic requesting a checkup. So when I asked him what he meant by a checkup, he actually showed me this lesion on his penis, or something similar to that, actually, because I borrowed a photo that was better. So the investigations that you would perform in this situation, because this person is high risk and also symptomatic, you do a PCR swab of syphilis for syphilis of the lesion. And you would test for everything, basically. So HIV, hepatitis B, surface antigen, surface antibody, and core antibody. You do a direct and indirect test for syphilis. However, when I had syphilis testing in pregnancy, my billboy obstetrician just wrote syphilis tests on the blood form. So just to simplify things, I actually think GPs get scared off with syphilis. And really, if you write syphilis test and the clinical presentation on the form, the lab will do the correct test. And it does get quite complicated because each lab has a slightly different test. So it is okay to just write syphilis test on the blood form. And I think that slightly simplifies it for everyone. But this particular young man, you do a first catch urine for chlamydia and gonorrhea and trichomonas, and you would consider hepatitis C and hepatitis A. So this particular person came back with a RPR of 1 in 32 and a TPPA, which was reactive. They were positive for gonorrhea and negative for chlamydia and HIV, and they had a low surface antibody for hepatitis B. So the treatment was benzathine penicillin, 0.9 grams in each buttock. And the benzathine penicillin is available now in the doctor's bag, which means every practice can actually obtain benzathine penicillin and keep it in their fridge, which is something else that's really important. The correct dose for syphilis, it's actually 2 big injections, 1 in each buttock. Is that right, Donna? It's not changed at all since... No. Yeah.
You are correct.
Yeah, we have had the problem is with the treatment for syphilis is it's very easy to get it wrong. So we have seen, for instance, people just getting 1 of the injections rather than 2 injections. We've also seen just the wrong type of penicillin being used, so benzyl penicillin being used instead of benzathine penicillin. So it is really important to get that dose right and to use the correct type of penicillin. But it has been made a lot easier now. It's available in the doctor's bag, and I know several of the practices now keep benzathine penicillin in their fridges. I'll come to the number of doses in a sec. So this particular young man would also need ceftriaxone and azithromycin for his gonorrhea. He'd need to do contact tracing, and he actually needs hepatitis B immunisation as well. Okay, so next part of the quiz. So what clinical stage of syphilis is this? So you can either type into the chat box or talk.
So you've got second.
Sorry?
Can you hear me okay?
I can, Kaylee. You're quite quiet, but yeah.
So second, primary.
Yeah, thank you. So this is primary syphilis. These are chancres. Now it's a bit tricky because we all learn at medical school that syphilis, it's a single painless ulcer, but in actual fact, in practice, you can get multiple chancres with primary syphilis. So I've certainly been tricked into thinking that syphilis was herpes because of the multiple ulcers. And you can get the ulcer anywhere. So you can get your chancre on a finger, we've seen. And this is a bit tricky because this one's got multiple ulcers. In this case here, actually that's a chancre, but it's actually on the mouth. So it can be a bit tricky to work out whether something's primary syphilis or, whether there's another cause for the ulcer. Okay, so what stage of syphilis is this?
So we've got secondary.
Yep, so this is secondary syphilis, and secondary syphilis can be the rash of secondary syphilis can be really tricky because it can present in all different sorts of ways. So you can get the classical rash, which is on the palms of the hands and the soles of the feet, but you can get all sorts of rashes, so mucus patches and psoriaform rashes as well. So look, if you've got someone with a strange rash, I do recommend just at the moment doing syphilis testing, because it is, look, you get the classical rash, but you get some really strange rashes as well. And you also can get condylomata lata, which can look like genital warts. So they're more moist, heaped, sort of wart-like papules in the intertrigonous areas in women. And you can also get mucus patches, which is showing, which is what this lesion in the mouth. And you can also get sort of a nodular rash. And I've actually hidden that slide, but yeah, we've had all sorts of presentation, and we did have a few years ago a lovely English backpacker, and actually backpackers can be considered at-risk group for sexually transmitted infections, as can people born overseas and people in prison and lockup. They were the groups I just thought that we've forgotten to mention, but we had a lovely English backpacker who presented with patchy alopecia. Donna may remember, who actually was positive for syphilis. So secondary syphilis is sort of really weird and wonderful with lots of different presentations. You can get primary and secondary syphilis at the same time, and there's lots of other symptoms that people can get, like hepatitis and arthralgia, but 75% of patients do get a rash. So congenital syphilis is preventable, and it is a drama. So I'm going to defer to Sue in a second, who's sort of the syphilis midwife. Is that fair to say, Sue? We've changed the screening guidelines for syphilis in pregnancy have changed, and I've just pasted them here. So because of the syphilis outbreak in North Queensland, everybody has a syphilis test at their first visit as usual. But we in GP, I mean, a lot of us in GP don't do much antenatal care anymore since the team midwifery system, but we do see people passing through our care sometimes. So people who are at increased risk are people who are Aboriginal and Torres Strait Islander, adolescent pregnancies, if they have an STI in their current pregnancy or the last 12 months, or if they have links to high prevalence countries. And the very high risk people are sexual contacts with infectious syphilis, Aboriginal and Torres Strait Islanders who reside in an outbreak declared area, ice users, if the woman's partner is a man who has sex with men, and if people have had very limited antenatal care. So if they're at increased risk, there's repeat serology at 26 to 28 weeks. But if they're high risk, they need repeated serology at 20 weeks, 26 to 28 weeks, 34 to 36 weeks, and also when the baby's born. So lots of increased syphilis testing in pregnancy. Now, Sue, do you want to add to that at all, if you're able to?
Usually, if they've, because a lot of them are having their first screening done through their GP really early, sometimes 6 weeks. So usually at first visit, we'll test again. So that's at about 16 weeks, and then go on, also do the 28 and 36, and then consider at birth as well.
So that's 5 tests in pregnancy, is that right?
1, 2, 3, 4 to 5.
Yeah, something like that. Yeah. Okay. Yeah. So just lots of extra testing in pregnancy because of outbreak and because of,
yeah, and any other if any other opportunistic, if they've contracted any other STIs or well, you know, they've had new partners, and so we're pretty much trying to, it's, you know, being pushed to test, particularly at the high risk at the moment.
Great, thank you for that, Sue.
Just with that, I was just going to ask you, how would you differentiate increased risk as opposed to high risk? You know, practically, are you better off if you're going to say they're increased risk? Would you just put them in the high risk category anyway and do the 5 tests rather than just the one at 26 to 28 weeks?
Yeah. So with the increased risk, this is where the continuity helps. So you've got to there's adolescent pregnancy, which is an increased risk. Obviously, some of those are socially at more risk than others. So there are some that I would just consider as high risk, and I probably wouldn't test quite as often as the ones that increase risk as opposed to high risk. Does that make sense?
Yeah, so there's not a clear kind of definition.
There's not a clear one, no.
Yeah, I always worry about those sort of moderate risk ones. It's a bit like in mental health with suicide risk, and we used to talk about a moderate risk, and it always worried me, the moderate risk. It wasn't low, it wasn't high, and you never kind of knew what to do with that group that fell in the middle.
Yeah. If in doubt, test.
Yeah.
In pregnancy.
So maybe it will be easier just to have normal risk and a high risk, Aaron. It's sort of, again,
that's what I'm wondering.
Saves confusion, doesn't it? So
yeah.
Okay, so there's a lot. GPs get very confused about diagnostic tests for syphilis. So the most commonly ones used, there's like an antibody specific test, which is the TPPA, which is used as a screening test. And then there's the non-treponemal test, most common, which is the RPR, which is used if someone has a past history of treated syphilis. Their TPPA or TPHA will always come back positive. So really you need to ask for an RPR at the same time. And you can also do a PCR test on a syphilis lesion. But look, I think it's okay to write the clinical details and ask for syphilis test on a blood test to sort of save getting terribly confused about different syphilis tests. So the easy way of doing it, because all the labs have different tests as well, is to write whether it's asymptomatic screening or whether they've had syphilis before and ask for syphilis testing. And with the result, my recommendation is always to ring the syphilis register with the result. So the most common positive result is someone comes back with syphilis TPPA antibodies because they've had syphilis in the past, but their RPR is negative. But often people come back with a positive RPR, which is used for deciding whether there's been a recent infection. The problem is that you can't actually ascertain whether it's a new infection or an old infection just based on the RPR. So 50% of people will have a persistently positive RPR. So really you can only decide whether syphilis is infectious or a new case of syphilis or not by comparing it to previous syphilis results. So basically, Claire's sort of simplistic way of dealing with syphilis is write syphilis test on the blood form. And if you get a positive result, ring the syphilis register and they'll actually tell you what to do. And it's appropriate to ring the syphilis register because they have past results on all patients who've had syphilis tests done in the past in Queensland. So they're a really fantastic resource, and it means that you're treating syphilis accurately. With the RPR, you have to have a 2 titer rise for it to be a new infection, and a 2 titer fall shows that there's been a response to treatment. Contact tracing, you need to contact trace all partners within 90 days. Basically the treatment for primary, secondary and early latent syphilis is 1.8 grams of benzathine penicillin. So that's 0.9 grams in each buttock. If they've got latent syphilis, so if you don't really know when the original infection was, or if it was more than 2 years ago, we actually give 3 doses of benzathine penicillin, so 1.8 grams weekly for 3 weeks. And if they have any sign of neurosyphilis, so a headache, or actually iritis, or any meningism, then they actually need to go into hospital and have IV penicillin, I think, for a week, but they do actually need hospital admission. Donna, I'm just going to ask you to interject there. Do you have anything to add with syphilis treatment? And as I say, yeah, we have had a couple of cases where people have been given a half dose recently. We did have cases in the past where people were given benzal rather than benzathine, but I haven't seen that happen recently. So Donna, yeah.
Thanks, Claire. 3 points. The syringes, unfortunately, the syringes have just been manufactured and changed from grams or milligrams to million units. So everybody needs to know that 900 milligrams now will be documented on the syringe and on the box as 1.2 million units. So every patient now needs to receive 2.4 million units, 1.2 million units in each buttock. That's the first thing. The second thing is that anyone who is pregnant, particularly beyond 16 to 18 weeks of pregnancy, of course, cannot have doxycycline, and therefore azithromycin and other medications are inappropriate. They'll have to be managed in a very complex manner by an obstetrician, perhaps Dr. De Silva, and perhaps an immunologist in Brisbane, because they will need to be desensitized to a severe penicillin allergy, and they will need to be given penicillin. And number 3 is coming back to me, sorry.
Okay, if you remember number 3, Donna, then just interject. Okay, thank you for that. Yeah, that's confusing with the million units, isn't it? I wish people wouldn't change things like that, because, you know, it's best just to keep things simple, because that could lead to dose confusion. So, yeah. All right, so, yeah, and so take-home messages for syphilis is try and increase syphilis testing in your practices, as we've mentioned before, possibly about to be declared an area of syphilis outbreak. Be really aware of people with strange rashes. Basically, you can just request syphilis serology, and generally the lab will do an antibody test and add an RPR if the antibody test is positive. Do a PCR swab if there's anything to swab. If in doubt, so yeah, if somebody's got symptoms, then treat them rather than waiting for the result. So I don't mean someone who's come back and just got a positive antibody test for syphilis. I'm more talking about, because you can ring the syphilis register, I'm more talking about if someone comes in with an ulcer or with a strange rash who's in a risk group, then rather than wait for the result, the current recommendation is actually to treat them for syphilis and get advice about the treatment. Donna's delighted to take phone calls about syphilis treatment, but also the syphilis register is an absolute wealth of knowledge about syphilis, and they have the results of people who've been tested at previous syphilis tests in Queensland. Okay, so any questions about syphilis at all? Or did Sue want to add anything, or Donna want to add anything? Everyone good? Okay, so we'll go on and talk about contact tracing. So first question is, whose responsibility is it to initiate contact tracing?
So we've got everyone saying A.
Yeah, so it's actually A. So it's great that everybody's said A, because certainly when I first started out in GP, I used to get chlamydia test results and it would say this has been notified to the public health unit, but notification is, and I thought, well, it's been notified, so public health unit will do the contact tracing, but there's a difference between notifying and contact tracing. So it's actually the diagnosing clinician or their delegate that needs to initiate the contact tracing. So the aim of contact tracing are to interrupt transmission, minimise complications and prevent reinfection, and it's key to STI control. Again, Ascham have got some fantastic contact tracing guidelines, which tell us how far we need to go back for every condition. So for chlamydia, it's 6 months, gonorrhea is 2 months, and syphilis, it sort of depends. The only thing that with HIV, in my experience, the HIV unit in Brisbane has done the contact tracing directly. Donna, is that still the case now? It used to be the AIDS medical unit used to do the contact tracing for HIV. Does that still happen?
Yes, so basically for HIV, it's a separate entity to the others because HIV requires, under the Public Health Act, for clinician to submit a HIV notification and a HIV contact tracing form under the Public Health Act. And it's up to us to write on those forms. HIV notifications can be done by the patient, but if the client doesn't feel comfortable, then it can be done by myself, or sometimes if it's very, very complex, yes, it will be done by the HIV contact tracing team in Brisbane, in which case I just get permission from the client to submit their full name and their mobile number, because under the Public Health Act, we only use the first 2 initials of the patient's first name and last name in terms of preservation of confidentiality.
Right. Thanks for that, Donna. So yeah, so I suppose HIV is in my experience with HIV, when I've started to broach contact tracing, it's actually magically already been done by the HIV contact tracing unit in Brisbane, so it is a slight exception. Okay, if there's any difficulties with contact tracing, again, the sexual health unit are delighted to help you with the contact tracing. And also Katie Edmondson. Where is Katie based, Donna?
Katie is based in Townsville.
Yeah, that's right. You can also ring her to help with support for contact tracing. So nowadays, most of the contact tracing is done through websites which offer anonymous partner notification services, which are just fabulous. I sometimes use them in clinic if I have one of the medical students with me to demonstrate. So there's the Let Them Know website is the common one, and Drama Down Under, which is a website for men who have sex with men, that has its own version of Drama Down Under, and there's also a version for Aboriginal people. So basically you log into Let Them Know and you click on Let Them Know. And you can basically, a patient, the index case, can notify by SMS their partners. And basically the message, this is the screen that comes up. You can send an anonymous SMS to the partner. You put in their name and number, and then you click which STI they need to be notified for. Then basically the partner will receive a message telling them that they've may be at risk of gonorrhea, chlamydia, whatever the STI is, and that they need a sexual health check. And basically they're referred to a website, the Let Them Know website, for more information. So it's very, very, very clear. It can be done in seconds and very effective. So a patient can actually do this on their own, or you can do this with a patient as the practitioner. You can sort of help the patient to send these texts, or the patient can hand it over to you as the practitioner to send the texts on their behalf. Donna, did you want to add to that? How do you do most of your contact tracing now? This is the bit where I wanted to defer to you. Yeah.
So just in a nutshell, contact tracing is extremely resource intensive and is very much a mix of all of those things. Sometimes we will assist the patient in our clinic rooms to send notifications via, let them know. A lot of times clients will say that they would prefer to notify themselves, the clients. Men who have sex with men will often notify the client via various social media applications. Sometimes we have to use letters because we feel that the clients are not well educated and probably don't have the internet at home, so we may have to use a letter. So it's a combination of phone calls, letters, and websites and text messages, and we use all of those, and we have to be very, very, very persistent. And really try. We're not always successful. We put a lot more effort into the HIV and syphilis streams than we do for the chlamydia and gonorrhea and trichomonas mycoplasma streams.
So in general practice, you recommend like tailoring the contact tracing to the particular client. And do you think that practice nurses in general practice can do you think that, how do you see the role of practice nurses in general practice in contact tracing?
I think that because a lot of GPs are extremely time poor, I think it's very, very suitable if they're comfortable with it. I think it's very, very suitable, and in my experience, most of the contact tracing in GP practices is done by the practice nurses. And if they don't feel comfortable, then they should please feel very comfortable to contact us to ask for help, or to Katie Edmondson.
Great, thanks very much, Donna. One more question. So Aboriginal and Torres Strait Islander people, who does the contact tracing for these particular clients in sexual health?
To be honest, a lot of it is done by myself. Again, it's very difficult because we can say that we need Aboriginal and Torres Strait Islander health workers to provide culturally sensitive care, but sometimes, particularly in the area of sexual health, the most culturally sensitive care is the care provided by a Caucasian nurse who doesn't belong to the client's tribe. And so it's actually received much more better for someone like myself, rather than a health worker at the Commonwealth Aboriginal and Torres Strait Islander Health Centre in Victoria Street contacting the client, because the client may have relatives or auntie and uncles working there. So it can be very tricky. So the bottom line is that Aboriginals, we don't even actually have an Aboriginal and Torres Strait Islander health worker in our clinic. Neither does Sue, I believe, at the moment. And so the work is all done by us.
Thank you, Donna. That's great to get the benefit of your years of experience. So thank you for that. Sue, did you want to add at all?
I was just going to say that's we did have a health worker, but she's left the position and it's vacant at the moment. But yes, I agree what Donna says. A lot would prefer to have that information not within their communities. And yes, an anonymous white woman is often easier for them.
Okay, thank you, Sue and Donna. So yeah, just so as Donna's alluded to, it's probably not appropriate to sort of let I suppose, trust the patient, or trust the patients to go out and do the contact tracing themselves without at least checking whether they've done it or doing it. Probably you want to develop a sort of partnership attitude to contact tracing in people with HIV, syphilis and gonorrhea diagnoses, or if there's repeat infections, or the Aboriginal and Torres Strait Islander communities, incarcerated people. So there's certain circumstances where you do have to be more fastidious about contact tracing than others. Just other tips, if it's provider referral, if the provider, you, the practitioner, is doing the contact tracing, you have to be very careful not to give feedback to the index patient. Do make sure that there's appropriate documentation, and make sure that within the contact tracing the patient is given or the partner is given access to prompt testing and treatment, whether it be through your own GP practice or through the sexual health clinic. Okay, so key messages about contact tracing. It's a component of good clinical management of STIs. GPs and practice nurses are well placed and skilled to take on the role as contact tracing, as Donna has mentioned, but it relies on the cooperation of the patient, and it's more important in certain situations than others. Okay, so any questions about contact tracing at all? Okay, so just a couple of things to just mention that are topical for GPs at the moment. So pre-exposure prophylaxis for HIV, which is also called treatment as prevention. So pre-exposure prophylaxis is basically a daily tablet of Truvada, which is an HIV, it's actually a 2-in-1 HIV medication, which is taken daily, or it can be taken sporadically as well, to prevent HIV infection. So it's taken by HIV negative individuals to prevent infection, and it's actually very effective. It's there's a 99% reduction in the risk of infection, and it was actually approved on the PBS in March 2018. So it is available, even though it's quite a costly medication. It is available to people who are healthcare card holders at for $6 a month. Who should go on PrEP? It's people who are a moderate risk of HIV, so it's mainly men who have sex with men. Before starting PrEP, we do an HIV test, and it has to be a sort of a brand new HIV test. We do STI screening and just renal function tests, because there's just a bit of a query about one of the medications and renal function in Truvada. And it's a streamlined authority script. The streamline number is 7580. So this can be done in general practice. After that, people go on 3 monthly cycles of STI screening, HIV and STI screening. So we often have people coming in and getting the screening tests and the scripts at the same time. And then they just have 6 monthly renal function tests. So it's really very straightforward. There's some ASHM guidelines on decision making for PrEP. There's very few downsides. I mean, it's a fantastic thing, really. The aim is to try and eventually eradicate HIV from Australia, and PrEP is a very good step towards that eradication. There's very low incidence of impaired renal function tests, and we only use it if the glomerular filtration rate is greater than 60, although we have had a few exceptions for that. There is an increased risk of STIs. So with PrEP, we actually give, it's like a public health intervention where we're giving information about public health, using condoms and safe sex, but people are having increased condomless sex as a result of PrEP. So we have seen an increased risk of STIs as a result of PrEP and people having condomless sex. However, it's also people are having lots more testing done, because they do have to come in every 3 months to get the script. So there is increased testing. I was a little bit, when I first heard of PrEP, I was a little bit skeptical. I was sort of like, well, why don't people stay home and have a cup of tea instead of, I don't know, going to the Mardi Gras or whatever. But I think I'm certainly on the side of PrEP now. Now I sort of basically understand the public health side of things. I'll just say that His Holiness the Pope actually wrote a letter saying that he supported PrEP, so I decided it was far be it for me to question it if the Pontiff actually supported PrEP. So it is an excellent intervention. So any questions about PrEP at all, or any comments?
It's Donna, Claire. It's just I wish there were more GPs, because I do get phone calls frequently from GPs saying, what do I do? I don't know what this is about, etc., etc. It's a wonderful thing. It's a concept a little bit like herd immunity. The more people who are on PrEP, the safer it is for this population. We probably have about 63 people at the moment who come to this clinic every 3 months, very regularly, for their PrEP scripts. And I'm currently joining in the National ASHM conference this week, so I've been listening in to a lot of posters and presentations on PrEP. So it's the way of the future. We're doing very well in reducing HIV notifications within Australia. We're doing much better in Australian Caucasian males than we are doing in our disadvantaged Aboriginal bisexual men who have sex with men.
Thank you, Donna. Yeah, it is a wonderful thing. It's not really taken off in general practice. When it first came on the PBS, we did actually quite a lot of education sessions for GPs, but it's not particularly taken off in general practice. But lots of people are accessing it. So yeah. Okay, we did put it out on Health Pathways. There is the PrEP for HIV, which will take GPs through it step by step, and links to all the relevant references and everything. If you're needing to put it, if you're time poor to explain it all to a GP, they should have it on their desktop. Yeah, that's great, Aaron. Thank you for that. Yeah, a very eminent professor rang me when JC saying, "Oh, I just had this person, they want to go on HIV treatment," and he really didn't understand what PrEP was. So I think it's still a bit misunderstood. But yeah, if it's on Health Pathways very clearly, that's a great resource. So yeah. All right, thank you, Aaron. So just another couple of things, then I just suggest we have a chat for 5 minutes. So medical termination of pregnancy, we did a webinar a month ago, I think, just to say that it is available in people up to 63 days of pregnancy. We prescribe it in sexual health clinic, but we like to really only see disadvantaged people who can't afford to have medical termination through their GP. There are also lots of GPs in town, a number of GPs in town who are offering medical termination of pregnancy services as well. So it's great that that's available. And yeah, we did this last week, so I won't go through it in huge detail. And I was just, mycoplasma, look, we're having a bit of a crisis with mycoplasma at the moment. Mycoplasma is very similar symptoms to chlamydia, and it's always been around. But then in 2005, we suddenly got a PCR test for mycoplasma, which was great. So we started testing everybody for it, and we found that the prevalence was about 5% in sexual health clinic, which was quite exciting. And we decided that the prevalence in GP was probably about 2.5%. But then, unfortunately, there started to be multiple drug resistance to mycoplasma. And unfortunately, it's sort of I suppose, a really good example of situations which you shouldn't screen for, because by screening and treating for mycoplasma, we've sort of created this situation of drug resistance. So what the current party line for mycoplasma is actually just don't screen for mycoplasma. And I didn't mention it in any of the screening tests. You only test for it in somebody who's symptomatic. And the antibiotic treatment of mycoplasma is now really complicated. Donna just showed me some new guidelines this week, and Queensland Health Laboratories certainly are starting to do resistance testing at the same time as the mycoplasma test, or when it comes back positive. So that's complicated treatment even more. So I would really recommend seeking help from sexual health if you have someone who's positive for mycoplasma about the appropriate treatment. And I'm sort of going to leave it there and not go into it anymore. And yet transgender, we just, is part of our sexual health clinic load. We've had a sort of a huge increase in transgender presentations at sexual health over the past 5 to 10 years. And really, I think it frightens many GPs, but really management of transgender people is fairly straightforward. There are guidelines. We take, generally, the main things in the history is to make sure that people don't have, well, people generally do have coexisting mental health problems, but really to make sure that they haven't got a psychosis, which is being masked as a transgender presentation, and also specifically asking about sexual abuse. We do investigations. We don't do, it's not necessary apparently to do a genital examination, and people generally aren't comfortable with that. We do refer everybody who wants to go on treatment for transgender to a psychiatrist. We use Dr. Caniato in Townsville, who's fabulous. And then people who've been approved to go on treatment, we put male to female transgender people, we prescribe cyproterone and some form of estrogen. And female to male transgender people, we use testosterone, usually Reandrin, 3 monthly, and they're regularly supported by a psychologist. So that's the other part of our, I suppose, our core workload in sexual health. Okay, so yeah, I think we've only got 5 minutes, but I'm happy for us all first to have a chat or take any questions. I'm just going to put the full screen on. Oh, Jasmine's there. Hi, Jasmine. Sorry, I didn't have the participants open. So Jasmine is the other doctor, in addition to myself, working in the sexual health clinic. We're both only there for 3 or 4 hours a week, and Donna is really it's a nurse run clinic, which works fabulously. So anybody, any questions or wants to talk about anything topical at all?
Just mentioning the transgender from a health pathways point of view, we haven't localized that yet. Do you think there's a significant need for it in our region? I mean, it's there, but I'm just trying to work out when it would be best to start localizing that, because we do have some examples of transgender pathways in the community.
Yeah, look, I think it would be a really good idea, Aaron. I mean, there's some really good guidelines. There's an MJA article, it's either 2019 or 2020, really up to date with really specific transgender management guidelines. So there's some great, I think it would actually be a fairly straightforward health pathway to create. So I think it would be a good idea to do one sort of now, but I'll get Donna's opinion as well. What do you think?
Sorry, yes, why not? And also Jasmine brought in the, what do you call that, Jasmine? The July or June edition of the RAC GP magazine. And
there's an article.
Designated to sexuality, and was really encouraging GPs to take on this area of care. Are you there, Jasmine?
Yeah, yep. So, the article is from the Australian Journal of General Practice. Sorry, my dog's barking. And it's basically encouraging GPs to care for people, transgender people, and it's got really good goals and guidelines and what to test. So I can pop a link in the chat if that's helpful.
But yeah, I mean, I think there is increasing presentations in GP land. So yeah, I mean, we've how many have we got on our books at the moment? Maybe we did an order.
Well, the truth is that 3 years ago we had 3, and now we have 40.
Yeah.
It really, the LGBTIQ movement has the rainbow movement has just surged on tremendously. And I could also just let you know that in Townsville, the transgender registered load at the Townsville Sexual Health Clinic has just hit 150, which is above the HIV positive load. And that's the first time that this has occurred since Arun has been the clinical director of that clinic.
Great, thank you, Donna. Okay, I'm just aware of the time that it's sort of 7:30-ish, so we might wrap up. Did anybody have any closing things they wanted to say at all? Aaron, we're very happy to help you with those health pathways. I say I am, but I think Donna probably will land it. So yeah, sorry Donna for volunteering you. So but yeah, so yeah, I think probably the two take-home messages from this evening are probably syphilis and gonorrhea. Remember to test and treat for both. Yeah, so thank you to everybody. Thank you very much again to Asham and Sabdi for sponsoring the evening, and thanks to Kayla for organising it, and thank you everybody for coming.